Welcome to this board review on joint pain and arthritis, brought to you by Roadmap to Residency. Joint pain is one of the highest yield exam topics, and the questions almost always test the same few decision points. Which joint problem is an emergency? When do you tap the joint? And how do you read the fluid? Our goal is not to reteach rheumatology, it is to show you how these stems are built and exactly how to attack them. Work through your question bank and a solid review resource alongside this video because these patterns stick best when you drill practice questions. Let us get started. Here is what we will cover. First, how to work up a single swollen joint, where the central skill is knowing when to aspirate and how to interpret the fluid. Second, how to separate the three big causes of an acutely inflamed joint: septic arthritis, gout, and pseudogout, using the clues the stem gives you in the synovial fluid. Third, osteoarthritis management, and exactly when the right answer is a physical therapy referral. Along the way, we will work through practice questions and explain why each answer choice is right or wrong. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is a reflex for any single hot joint. When the stem describes one joint that is acutely red, hot, swollen, and painful, your first move is to aspirate it. Arthrocentesis is the test that changes management, because the fluid tells you whether this is infection, crystals, or something else. Reach for the tap before imaging or a long blood workup. This matters because the one diagnosis you can never miss is a septic joint, since bacterial infection destroys cartilage within days, so even when the stem nudges you toward gout, with a big toe and a steak dinner and some wine, the correct next step for a single hot joint is still to aspirate and send the fluid for a cell count, gram stain, culture, and crystal analysis. Never treat gout before you have excluded infection. Strategy 2 is reading the synovial fluid, because once you can read the fluid, these questions almost answer themselves. Start with the white cell count and let that number lead you. A very high count that is mostly neutrophils, especially with a positive gram stain, screams septic arthritis and demands urgent treatment. A moderately elevated count with negative cultures points toward crystal arthritis. A low, clear, non-inflammatory count points toward osteoarthritis. Anchor on that number first. Then, once infection is off the table, let the crystals name the disease. Needle-shaped crystals that are negatively birefringent, turning yellow when parallel with the light, are uric acid, and that is gout. Rhomboid crystals that are positively birefringent, turning blue when parallel, are calcium pyrophosphate, and that is pseudogout. Memorize those two pairings cold, because the exam hands them to you as free points. Now the TRAPS test writers love to plant. First, do not skip the tap just because the gout story is perfect. When you see the red, exquisitely painful big toe after a rich meal and alcohol, it is tempting to jump to treatment. But if it is a first attack or infection is possible, the correct next step is still to aspirate and confirm the crystals. Second, a normal uric acid level does not rule out gout. The serum level can be normal or even low during an acute flare, so a normal value never excludes gout, and a high value never confirms it alone. If an answer choice hangs the diagnosis on the uric acid number, treat it as a distractor. Third, treat the flare first and worry about the long-term cause later. During an acute attack, you calm the inflammation with an NSAID, colchicine, or a steroid. You do not start uric acid lowering therapy in the middle of a flare, and you do not stop it if the patient is already on it. Let us work through our first practice question, which tests whether you will protect the patient from a missed infection. A 68-year-old man comes to the emergency department with one day of a red, hot, swollen, extremely painful right knee. He has a fever, cannot bear weight, and resists any movement of the joint. Here is the trap. The stem tells you he has a history of gout in that same knee, dangling the easy diagnosis in front of you. The question asks for the most appropriate next step. Remember that a single hot joint with a fever must be treated as infection until proven otherwise. Read the 4 options and pick your answer. Then we will walk through the reasoning. Let us break this down. First, spot the danger. A single joint that is red, hot, swollen, and painful, with a fever and inability to bear weight, is a septic joint until proven otherwise, and the history of gout is a deliberate distractor. A patient with crystal disease can absolutely develop an infection on top of it, so the past gout does not make you safe. Next, apply the rule. The next step for any acutely inflamed single joint is to aspirate and send the fluid for a cell count, gram stain, culture, and crystal analysis, because only the fluid can separate infection from a crystal flare. So the correct answer is to aspirate the knee and send the fluid. Now eliminate the wrong answers. Starting colchicine treats gout before excluding infection, and that delay lets a septic joint destroy cartilage. Ordering MRI just delays the one test that changes management. And checking a uric acid level does not help, because it can be normal during a true flare and never rules out infection. See how the single hot joint reflex carried you straight to the safe answer. Here is our second practice question, a pure crystal identification question, which is about as high yield as it gets. A 72-year-old woman comes to clinic with a swollen, painful right wrist for 2 days and no fever. The wrist is aspirated, and the fluid shows a moderately elevated white cell count, a negative gram stain, and the key detail, rhomboid-shaped crystals that are positively birefringent and turn blue when they line up parallel with the polarized light. The question asks for the most likely diagnosis. Everything you need is in that crystal description, so match the shape and color to the disease. Pick your answer, and we will reason through every option. Let us work through this. First, read the crystal clues. You have moderately inflammatory fluid, a negative gram stain, and rhomboid crystals that are positively birefringent and turn blue when parallel with the light. The negative gram stain and only moderately raised count push infection down the list and point toward crystal arthritis. Now match shape and color to the disease. Rhomboid, positively birefringent, and blue when parallel means calcium pyrophosphate. And that is pseudogout, so choice C is correct. Now eliminate the rest. Gout would be the opposite crystal, needle-shaped, negatively birefringent, and yellow when parallel, so choice B is out. Septic arthritis is very unlikely with a negative gram stain, no fever, and a modestly elevated count, so choice A is out. And rheumatoid arthritis is not a crystal disease and usually attacks many small joints symmetrically, so choice D is out. A great memory hook is that pseudogout is positive and rhomboid, with both words giving you the P sound. Now managing osteoarthritis, because the exam tests the treatment ladder in a predictable order. First, start with movement, not pills. For osteoarthritis of the knee or hip, the first line answers are almost always the non-drug, non-surgical ones. Weight loss, a structured exercise program, and a referral to physical therapy to strengthen the muscles around the joint come first. So when a STEM asks for initial management in a patient who has not tried these things, the physical therapy and exercise answer usually beats jumping to medication. Second, step up the ladder only when needed. If pain persists, the next steps are topical or oral, NSAIDs, with acetaminophen for patients who cannot take those. An intra-articular steroid injection can settle a bad flare. And surgery, meaning joint replacement, is the last resort for severe disease that has failed everything else. Watch for stems that tempt you into jumping straight to surgery before conservative care, because that is a classic wrong answer. Here is our third practice question, testing where the osteoarthritis treatment ladder begins. A 58-year-old woman with obesity comes to clinic with a gradual ache in both knees for over a year. The pain is worse after activity and at the end of the day, and better with rest. There is no redness, warmth, or swelling, and her morning stiffness lasts only a few minutes. That picture is classic osteoarthritis. The detail that should anchor your answer is that she has not yet tried any structured treatment at all. The question asks for the most appropriate next step. Think about the very first rung of the ladder and be careful of answer choices that leap ahead to surgery or imaging. Choose your answer, and we will reason through every option. Let us break this down. First, recognize the pattern. Activity-related knee pain that worsens through the day and improves with rest, with morning stiffness lasting only a few minutes and no warmth or swelling, is textbook osteoarthritis. Now start at the bottom rung. This patient has tried nothing yet, so the correct first step is conservative care, meaning referral to physical therapy along with weight loss and an exercise program. That is choice A, and it is the answer. Now the wrong choices. Referring her straight to orthopedic surgery for a knee replacement skips every conservative step and is far too aggressive for someone who has not tried therapy. Starting long-term daily opioids is inappropriate for osteoarthritis and exposes her to real harm for little benefit. And ordering MRI of both knees is unnecessary when the picture is already classic and would not change your initial management. Each distractor does too much, too soon. Here is the single most valuable pearl that ties these questions together: the single hot joint rule. Whenever a stem hands you one joint that is acutely inflamed, red, hot, and swollen, especially with any fever, your default first move is to aspirate it and send the fluid for a cell count, gram stain, culture, and crystal analysis. Do this even when the story looks like a perfect gout attack, because what the exam is quietly testing you to prevent is a missed septic joint that destroys cartilage. Then, once infection is excluded, let the crystals lock in the diagnosis by matching shape and color. Needle-shaped, negatively birefringent, and yellow when parallel is gout. Rhomboid, positively birefringent, and blue when parallel is pseudogout, and never trust the serum uric acid level on its own because it can be perfectly normal during a true flare. Master this one rule and you will pick up a surprising number of points. That wraps up our review of joint pain and arthritis. Remember the core ideas. For any single hot joint, your reflex is to aspirate and read the fluid, and you never treat gout before excluding infection. Let the cell count separate infection from crystals, then match the crystal shape and color to name gout or pseudogout. For osteoarthritis, start at the bottom of the ladder with physical therapy, weight loss, and exercise before you consider surgery. The best way to lock this in is to drill questions under timed conditions and read every explanation, even on the ones you got right, while reinforcing the details with a trusted board review resource. Visit roadmaptoresidency.com for expert tutors and advisors who can help you build a personalized study plan. If you found this helpful, please like and subscribe. Good luck on your exam, and we will see you next time.